habari za jioni.
Njema.
Karibu.
Asante. Tunasubiri kipindi.
Sawa, tunashukuru kwa kuja. Asante. Wako mwingine?
Hapana, niko KCMC.
KCMC. Oh, nice. Okay.
Yeah.
Uko sehemu gani?
Niko idara ya upasuaji, ni resident.
Yes. Oh, nice. Okay, sister.
Okay.
Yeah. No, I think Miss Victoria, Dr. Sango is resident in one of the hostels in Arusha or Moshi.
Good morning, Dr. Sango.
Good morning, Mrs. Victoria.
KCMC.
That's the name of the hospital?
Yes.
Arusha.
Yes, I think it's Kilimanjaro Christian Medical Center, right?
Yeah, yes. It is Kilimanjaro Christian Medical Center, situated in Moshi, Tanzania. Just
okay.
Below the mountain Kilimanjaro.
Oh.
I know, we need to go there.
Yes, we do.
Hello.
Yes, hello.
Hello.
Good afternoon.
Good afternoon. How are you?
Habari za mchana.
Mary from the Gabone Health Center.
Oh, Buguruni, yay! What's your name?
Mary from Buguruni Health Center.
What did your name said?
Mary from Buguruni Health Center.
Oh, Dr. Kilowoko?
Yes, Kilowoko.
Yes,
Kilowoko.
nice meeting you.
Yeah.
Karibu Kilowoko, Dr. Kilowoko.
Asante, thank you very much. Asante Sana.
No, we appreciate you coming in. So she's the person in charge of Buguruni. So we are looking forward to come and see you. 18 days.
Yeah, you are welcome. We're waiting for you.
No, thank you.
You're welcome.
Thank you. Yes, we're definitely going to have a little fun and learning.
Oh, yeah, for sure.
Yes. No, thank you for coming. I think it makes, Mrs. Victoria, we can start. So welcome everybody to our very own first burn training, and among of 9 training that we've been provided from QHSC. These are training and preparations for our medical mission, which will be in September 12th to September 24th. And we are excited, and just for a little background, we have 46 people coming to the training. So we are so blessed and excited, and there's a lot of training going on, including the wound care, which Mrs. Victoria is going to give us a little brief, and then I welcome the questions at the end, so then she can have all the content done, and then we can discuss. The goal is just to get more information before she gets there, more information of what you guys are doing now, and I'm grateful that Dr. Sango and Dr. Kilowoko is here, so you can give us the perspective from KCMC and Buguruni, so at least we learn what exactly is going on. And then so she can prepare or focus on the area that you guys need more help or more assistance or more discussion. And she's going to give you more information. But so we do have Mrs. Victoria here. I'm going to give her a few minutes to introduce herself. We have Mr. Siakabe, our Vice President for QHSC, and I'm going to welcome Miss Victoria. Welcome. Start.
Good morning. Good morning. So thank everyone for coming on and waking up to be on the call for those of us that's here in the States. So on my, well, first of all, to tell you a little bit about myself, I am a wound care technician, burn specialist by profession. And I worked at the Parkland Burn Hospital, Burn Center in Dallas, Texas for the past 30 years, interchangeably as a research coordinator and as well as a wound care technician. And along the time span, my role changed interchangeably to be a preceptor to the new incumbents for wound care, as well as training the graduate nurses, and also training the first year intern residents, doctors, to the burn center and orienting them to just burn care and how to get started in their first year. So I hope I say something that's going to either benefit or demonstrate and be beneficial to each listening ear this morning. So let me start by saying last year I got a chance to go to Tanzania. Yeah. And so thankfully, Dr. Harriet was gracious in inviting me to go. So I got a chance to go to Muhimbili Hospital and meet with Dr. Rimmer. He was very welcoming and showing me around the burn center and taking me to the burn clinic and just kind of showing me his day in and day out duties of what he does. And he invited me back, and so I'm happy to be invited back. I'm gonna go to next. So the title of my presentation this morning is called More Than Wound Care. And I named it this title simply because to me, it was more than wound care. It eventually became a ministry to me. And I began to see that there was a need greater than just the wound care itself, but to care for the total mind, body, and spirit of the survivor patient. So first, we'll start off talking about exfoliative diseases. Exfoliative diseases by way of TENS, which is called toxic epidermal necrosis, is a rare life-threatening skin reaction, and it's usually caused by a medication, for example, kidney medications that are used for kidney stones as well as gout, and then some medications that are used for HIV. Usually patients will get this skin reaction. It's also triggered by some vaccine medications as well. And in the patients that I've seen, they are very, they become very sick, and they, in some cases, depending on if they have any other concomitant diseases along with that, their health declines really quickly, and they become sometimes become septic. So some of the cases that appear, the cause is not known, but for the cases that we have come in contact with, it does wide damage to the skin, widespread damage to the skin. For some of the patients that I've seen on contact, they initially come in with huge blisters, and the skin is sloughing, and for the most part, they can't tell you what happened. They just, know that it happened, and they're there at the hospital in an emergent situation. And so, they find themselves in that critical stage of trying to figure out what's going on and how can it be treated. So for the most part, they're subject to lose a lot of fluid. And so it's very important to resuscitate their fluids, initially when they're first admitted. I've found in my practice that a lot of these patients go on to have MRSA or Pseudomonas, and generally on admission, we are instructed to culture them. So we will culture them in with a red Petri dish and send it to the labs so that we can determine what was the, what is the culprit of the whatever bacteria that is growing on the wound as well. So a more severe form of Steven Johnson's is the TENS, which is considered greater than 30% TBSA. and it involves the mucous membranes like the mouth, the eyes, and the genitals, and any other mucosal orifice. So in my experience, I think these patients are the worst because it's, for me, trying to care for them, you don't know how to handle them as far as bleeding. There's lots of bleeding from the membranes, shall I say. So it doesn't just involve being on the burn unit and being cared for by the burn unit. Normally there's other disciplines that are involved, especially the I'm sorry, I'm lost for words right now, but there are other departments that are involved that will get consultation. They'll have consults for these patients as well, except especially like the optical department when it's involving their eyes especially. So I didn't include pictures on this particular slide, but when I do come, I will have pictures to show for patients that have had eye involvement with this particular condition. So about 25% of these patients usually don't survive, and that's because they become septic. And when they become septic, of course, they go down real quickly, and they're to the point of no return. All right, help me, Dr. Harris. I'm trying to
Just go next.
no, I can't pull up my bottom screen. It's not coming up for next.
From your laptop, you can just click next.
Okay. So usually the symptoms for TENS develop within a few weeks of the patient being on whatever antibiotic or whatever medication they have. And it normally starts out like little small blisters on the skin. And from there, it progresses to more pronounced blisters, if you will. And the patient experienced body aches and cough, fever, and chills. So not to be mistaken with any other kind of, I don't know, the flu or something like that. This condition is very characteristic by the blisters that it form on the skin. So along with the blistering, it causes like a lot of pain, pain on contact, and just pain in general. And so, like I said, the wounds progress to very large blisters, and it sloughs, the skin is sloughing. And like if you see it on a broader base of the body, like maybe the back or the abdomen or the thighs or something like that, normally it's horrendous when you're taking care of it. And when we're initially on contact, we're instructed not to take the skin off. If the blister hasn't already been burst, we're generally instructed to leave the skin intact and just work around it and try to maintain that fluid. But or we may take a TB needle and just prick the edge of it just so that the fluid can seep out, but the skin is still intact. And sometimes it's not necessary to debride the skin away from that particular area. So it usually starts on the face and the chest, like I say, with little small blisters, and then it spreads to the cornea or the conjunctiva of the eye, and it becomes more severe and more pronounced. If it becomes a situation where the mucous membranes of the nose and the mouth and the throat and the airways are involved, then generally they have to be intubated. They are usually sent to the unit to be intubated to maintain the airway. In other areas, as far as the genitals, especially on females, I've seen it such that either they have to wear vaginal stretchers to keep the vaginal tract from, I guess, growing together, if you will. Also, it makes it difficult for the patient to eat, so therefore it's necessary to give them 2 feet because of all the bleeding from the different orifices. And some of the life-threatening complications of TENS can include infections and multiple organ failure, as well as pneumonia. And again, I already mentioned sepsis. And so Dr. Moses and Dr. Mary, feel free to jump in, add to whatever's being said, if you will.
Yes, I think most have their microphones muted. If they want to unmute and they want to add something or.
Okay. So I'll go ahead to a case study that I did of an electrical wound. And this was a young man that sustained an electrical wound from a high wire. He is a tree trimmer by profession, and he came to us. And so this wound is like more cleaned up now. But when he first came from the pit, from the ER, his skin was just like blasted open. And this is a more down version after he's had some debridement and after it's been cleaned up. So if you look at the picture, you can see he had several exposed tendons, entry wounds, and then like the big circles and holes in his hand were like entry wounds. And subsequently he wind up having to have his fingers amputated. I think it was his 3rd and 4th digit that he had to have amputated. But he had extensive surgery and had to have muscle flaps. And I'm not sure if you know what muscle flaps are, Dr. Harriet, but the muscle flaps were—
No, I don't.
Okay, so he had to have a muscle flap, and that's where they take healthy muscle tissue and they take the wound bed and they turn it down towards the healthy muscle tissue to help it to regenerate and epithelialize to new skin cells. And so I think he had to stay like with his arm attached to his abdomen for a period of maybe 2 weeks straight to try to help regenerate new skin cells and grow new muscle tissue. And so they eventually will take it apart to see the progression of the healing. And if it's necessary to do that muscle flap again, they'll do it again to help it, continue on this healing process. So I happened to be his caregiver, and man, the first day I saw him, the tendons, the muscles, everything was pulsating. He was in so much pain, and he was just trying to be all strong. And I was like, sir, this is painful. It's painful for me to even care for it. So I need you to express your pain and don't try to be tough. Just let your pain, let it take course, and you cry if you have to. And trust me, after I said that, he just, kind of released that toughness and just let it all out. So we became very, very well connected from that point. He got to where he only trusted me to do the wound care. And because I took my time with it, and because I was very meticulous about how I would take the bandage off, because daily the bandage was like glued to the tissue. And so you could just see it pulsating and just throbbing, you know, while you're trying to get it loose. And so I just took it upon myself to make that my daily, you know, grind with him as my patient. So he's going to give a little testimonial.
Oh,
Is that okay?
no, we can't hear it.
The volume.
We still can't hear it.
You can't hear from your side?
No.
No, I can't.
Oh, okay.
Yeah, we can't hear it.
Okay. So basically what he's saying is that basically what he was saying was that when he got to the unit, they did a fasciotomy on his forearm and some other life-saving measures. And then he met me probably on the second day that he got there, being transferred to the floor. And then from that point on, I became his permanent caregiver. And so I've maintained that communication with him even throughout the time that he's healed and went on about his life. I've still maintained contact with him as well as other people that I've cared for over the time frame. And so if you saw on the picture, he was showing his amputations and things of that nature. And even now he'll call me in the wintertime and ask me, you know, he has a lot of nerve damage as a result of that. And so he'll call me and ask me, you know, what kind of garment should he wear because he's cold and can't get warm. So he's lost a lot of sensation in that extremity. Another case study that I did of exfoliative diseases of the skin was a young lady who had Stevens-Johnson's. And to tell you a little bit about Stevens-Johnson's, this is also interchangeably with TENS. And so, but Stevens-Johnson's normally is less than 10% TBSA, and TENS is greater than 30% TBSA. So the percentage in between the two is when they refer to it as Stevens-Johnson's / TENS. And so it's normally spoken of or referred to interchangeably sometimes on the unit that I worked in. And in order to treat the Stevens-Johnson's, we use like a triple antibiotics ointment, as well as cool compresses on top of that. And the bandages are usually changed like 2 to 3 times per shift, per 8-hour shift. And mainly that's to minimize the susceptibility of infection. So these are some pictures of a patient. And this starts the progression of the Stevens-Johnson's. As you can see, her skin is beginning to turn red. She experienced this by taking Bactrim. I think she had just had a baby, and she was prescribed Bactrim. And then afterwards, she had this big celebration of a program and everything, and she invited me to come. And she wanted to share her testimony of what she had experienced. And so I couldn't speak because I was crying. I was so happy for her. She pretty much stayed in the hospital about a good 5 weeks. And after she got out, you know, she was just very grateful. And this is her today.
Oh, wow.
Mm-hmm.
Yes, incredible.
Incredible. Yeah. To move on with diabetic wounds, I didn't really do a whole lot on this topic, with the exception of just pulling up. I didn't have any personal stories to tell. We generally get diabetic patients from the foot clinic, and normally when they come to the unit, they're already in progress and their wound is already pretty much involved. So we're just there to clean up the wound and debride it and get it back to its healing stage. So a takeaway from having diabetic wounds, I would encourage a person who is a diabetic to always test the water before they stick their extremity in it, because sometimes they've already lost feeling in their extremity that's involved, and they cannot tell if the water is hot or if it's cold or whatever. So if they stick their feet in the water and they feel that the water is not cold, they're going to turn it up super hot, and they've lost the sensation and they can't feel. So that's when they incur the burn. And so either they'll have to have someone else test the water for them if they don't have that much sensation in their feet or hands or whatever. And then also I would encourage them not to step on any sharp objects and to wear proper fitting shoes, because the skin is already compromised. So when it's compromised, it's very easy for it to break open and cause a wound, and then it becomes more detrimental to them. So the integrity of their skin is already poor. So it's very important to take precaution as a diabetic. Questions?
I have few, but I'm gonna let other people. Yes, Dr. Sango, Dr. Maple said.
Can I say?
Any questions? Oh, Dr. Asad too. Any questions? I have few. Have you guys seen the patient with the Steve Jones and you have managed them? If so, what medication did you use? I know she said you took antibiotics. What medication did you use if you've encountered that patient?
Dr. Sango.
Oh, yes. Dr. Sango, go ahead.
I have a question.
Yes.
I'm not trying to answer that trip antibiotic, but
Okay.
I have a question. I saw that patient with erect Coban.
Okay.
So I was interested in knowing how was his wound cared. Did they use some vacuum assisted wound?
So I think early on he was receiving saline packs. He was receiving saline packs, just wet soaks to the wound to get the wound bed clean and make sure that it wasn't infected. And after the skin began to epithelialize, then they were more aggressive as to do the muscle flap. So, and then after the skin began to epithelialize to where it could be grafted, it was grafted. But I think I remember one instance where he had a wound vac, and the wound vac, for those of you who are wondering, is like a sponge, and you place the sponge over the wound and it fits in every groove of the wound. And then there's a tube that's connected to the wound, to the sponge, and the tube goes to a machine, and then you turn the machine up to a certain frequency, and it sucks the fluid from the wound, if you will, to make it be susceptible to be preparing it to be grafted.
Okay.
So yes, to answer your question, he did have a wound vac at one point in time.
Dr. Said? No. Going back to Dr. Sango, any for those, I mean, I know you are in the surgery world. For surgical patient, I mean, have you experienced the patient who has that kind of wound, and then you guys did the surgery? And if so, what did you guys do for that type of a patient?
So currently we receive many patients with wound, as KCMC is one of the tertiary hospital in the northern part of Tanzania. So in most of the wounds that we care, they are patients with burn wound and those.
Oh, you muted.
Do you hear me?
Now
Yes.
we
Now we
can,
do.
yeah.
Yes, now we can. Yeah.
What I was trying to say, KCMC is one of the zonal referral hospital in Tanzania.
Okay. You're muted, Dr. Sango.
Do you hear me?
Yes,
Now
now.
we can, yes.
Yeah, what I was saying, that at KCMC, the zonal referral hospital in the country will receive many patients with wounds. And most of the common wounds that we see are these diabetic foot ulcers. Those are common. And bad enough, they come at bad stage, of which you have a wound which is almost Wagner 5, on which when we say it's Wagner 5, is having the gangrenous change. Most of the time, it's hard to save those patients. Other patients receive the patient with the burn wounds, we care, and other wounds are this trauma, or those post-surgical wounds. Maybe the patient had burst abdomen, then you have a big wound to take care of. So we don't use VAC. VAC is not frequently used at our setup because we do not have access to it. But we just use the conventional wound dressing that we have.
So do you
Saline.
find that in using the and just treating the wound the conventional way as opposed to having the VAC, have you ever been able to have access to VACs?
We tried 2 times. We had patient we just improvised. We use these suction machines we have, the regular suction machines we have at the hospitals. Then we tried for 2 patients, though it did not work. The problem is the VAC machine devices themselves, they are not available in our place.
Mm-hmm.
Yeah, so most of the time we take care, we do the conventional dressing. When the wound is somehow good, we do grafting.
Okay. So in other words,
So,
it takes the wound a lot longer to heal, correctly?
yes. And the patient has a long hospital stay.
Yes.
For instance, we had a patient who presented to us with a wound on the right leg. This wound was on the anterior and the medial aspect of the leg.
Mm-hmm.
And the patient, we were thinking that possibly the wound was, we couldn't do grafting because the patient had low platelets. So that's the wound posed a challenge today because we have not yet been able to cover the wound.
Now, was this a burn wound or a diabetic wound?
It's not a diabetic wound, neither a burn wound.
Mm-hmm.
So we are querying maybe to be due to an autoimmune disease that we did not know, because the patient, yes, had this splenomegaly, had low platelets, and had that wound. She is a lady who is almost 50 years old.
Mm. So is she receiving blood?
We gave multiple transfusion, but we gave fresh whole blood, but we were not able to like the platelets. The platelets were 30 something.
Mm. Okay. Thanks for sharing.
Okay, thank you.
Dr. Said, do you have anything to add? Or your experience in these patients? who have wound? Dr. Kiwoko, are you still an infinity one? Anna Malere, any comment? Wound care, diabetic?
I have no any comment.
Okay,
So I have a
I
question
have
for
no
Dr.
comment.
okay, thank you.
Okay. I have a question for Dr. Sango again. So you say that you do receive patients with traumatic injuries like electrical. So how are they brought to the hospital? How are they transferred?
Because these patients normally they are attended from the lower level hospitals nearby. Normally they are brought by ambulance with an escort nurse, where they'll be received at the emergency department. From there, the initial the emergency wake-up will be done, and the patient later will be transferred to burn unit, where there are nurses who take care and there are doctors at burn unit. But normally they are transported by the ambulances.
Okay.
Do you guys, Dr. Sango, do you usually also include like nutrition for patients who are experiencing burn, like diet, something that to help with the healing while they're in the hospital? But you said this patient was in the hospital a bit longer. So what other things other than antibiotics or the dressing change, what other things diet-wise was included in this patient?
Currently, when we receive patient with wounds, we look at the factors which will affect wound healing. One of them being nutrition and infections. So we check at all parameters, and so far currently we are working with dietitians who normally pass rounds and see this patient. And we try to optimize all the factors that impairing wound healing. But the problem is that for patients with maybe who have major wounds, especially those patients that have undergone surgeries and will be ill for some times. Now getting what parental nutrition is somewhat hard, because you might need to give them the TPN, which is a bit expensive.
So how do you determine who gets it?
How do you determine who gets it? If patient can afford, and if patient cannot feed orally, and you think that the patient will benefit from, if they are economically able to afford, then they buy. They are available locally, but it's expensive to get one.
So I think for coming from a big hospital here in the States, I could say we're with TPNs and other fluids and other I guess NG tube feedings and stuff like that. I think we could be a little bit more cautious with how we, go through it or whatever, being that the scarcity, for you all is greater. So I think we could be a little bit more cognizant of how we go through those substances as we administer it to the patients.
I would like to know, how do you go? How wise do you give?
Say that again.
I would like to know in your practice in regard to those fluids and the TPN, whatever. Who gets?
Pretty much every patient that deems necessary to have it. I don't think there's no discretion. If the doctor thinks that they need to be on TPN or any special fluid regimen or tube feed or anything else, it's just automatically written and they receive it.
Okay.
It's automatically ordered and they receive it. So I don't think it goes by the fact that they, you know, their insurance can afford it, or if not, whether they have insurance or not, they just automatically receive it because they're planning to carry costs for it.
Okay. In with regard to the blisters in your practice, how often do you have to remove them, or you always leave them, the blisters?
The blisters.
Blisters.
Oh, how common do we have to remove the blisters?
Or how often do you leave them?
We only leave it if the blister is still intact, especially if it's a blister that covers a large portion or surface of the body. We are encouraged to leave that intact. And if they're like blisters that are, I don't know, say, especially blisters on the face, things of that nature, if we can leave the blister intact and preserve that skin integrity, we leave it intact and we just wrap it. But otherwise, we're pretty much not encouraged to remove the skin on those type patients. But sometimes you're going to know in transferring the patient from the tank or from the treatment bed back to their regular bed, there's going to be some, you know, when you're handling the patient, of course, their skin is going to slough or however, but for the most part, we're encouraged to leave it intact.
Okay.
Mm-hmm.
Thank you.
Thank you.
No questions, but I did have Stephen Johnson's disease a couple years ago.
Well, so can you share some of your experience about it?
So I had a UTI and Bactrim wasn't working, so I went back and the doctor put me on Cipro.
Mm-hmm.
And then I started getting like sores in my mouth, but I thought it was my toothpaste, so I didn't say anything because I had switched toothpaste. And then all my mucous membranes started getting affected. So I went to JFK and they didn't really know what it was. So then my hands and feet started getting very bad blisters. And at the time I was working for dermatology. So the doctors that I was working for came and they were like pushing the other doctors, like it's Stephen Johnson's disease. And so luckily they caught it early enough, but I did need like blister debridement. I did need fluids. I did need artificial tears. I did need the cold packs and all of that.
Mm-hmm. So generally I find that the person who is experiencing this, they do not know that, you know, it's better if they get to a burn unit as opposed to going to a dermatology service or something like that. And then generally I also find that other hospitals that does not see burns so often or does not see those kind of skin conditions, they either don't know how to treat it or they will treat it with something that, you know, they think it should be treated with, which will make it worse.
Yeah, but thankfully I had a full recovery.
Right. So time is of the essence.
Yes, ma'am.
Thankfully,
Thank you.
yes.
Yes, we are grateful that, Bree. Wow. No, but that's just so interesting, you know, as Mrs. Victoria Jones just said, when you get those blisters or you get any skin conditions, you don't think of burn because we are conditioned in our head that burn, like you actually have to get close to the, you know, like a chemical burn, electrical burn, hot water, whatever. I mean, that's what we think. We don't think that things can be internal and happening in our body without, you know, actually the flame coming out of it. So yes, it takes a long time, and I'm glad for the case of Miss Bree, things turn out to be great because she was early diagnosed with the help of co-workers. And then so, but the lady you share in the case study, that is scary, you know, like situation. So if you see like your face is burning and changing all this stuff, it's incredible that when you see her now, it's a different person. And
Actually, for her, her airway was significantly impacted and she had to be intubated initially. And I think she was intubated for like 2 days. And then they transferred her to she actually got transferred from another hospital to the intensive care unit. And so actually when they extubated her, she came to the step down unit, and it was a riot between her, the family, and not knowing what's going on. And, you know, I don't want this, you know, I was over here at this hospital, so why did they move me to this burn center? She's not burned, you know, so you got to go through explaining how the wound progressed to, you know, what it was when you saw it on the picture, and where does burn service come in to play a role in treating her wound. So that was a hard transition for her and her family. And, you know, they kind of equated the care to, is my insurance not good enough? Why did they transfer us from this hospital? Because it's a private hospital and this is where we want to be. Well, it's not about that. It's about her care and the care she needs. So she was transferred to this hospital. So, you know, it's a bit of a struggle there, but once they were there and received the care, you know, they couldn't stop singing the praises of the care they received. So.
No, definitely that makes sense. And early detection is always a great prevention of complications. So, Dr. Kilowoko, do you have any comments, questions? Have you seen type of the patients in your hospital at Buguruni? No. If you're talking, you're muted. But anyway, I think it's just a great opportunity that we're able to learn. As I said, we as a healthcare user too, we always think burn as I said before. So thinking of that antibiotic can make things worse. Then we always like, if you have a little sickness, pain here, cough there, we always like, why can't the doctor give me antibiotics? Yes, so we don't know that the medication that you are asking for sometimes unnecessarily could lead to things that nobody might be able to early detect, and then you might end up in trouble with other complications. So I think it was a great learning opportunity, and Mrs. Victoria Jones, thank you for sharing that part. So if there's no other questions, if you want to give us a little summary, things that you want us to take away from this training, and then I will let people go back to work.
Well, if my summary will be for diabetic wounds, those of you with diabetic wounds or know someone who has diabetic wounds, is to pay attention to what you're doing. Pay attention to the temperature of the water that you are about to use when you're bathing or soaking your feet, things of that nature. For prescriptions, especially sulfa drugs, always read the little epitaph that they put attached to the medication. Read about the adverse reactions that it could cause, and so you can be aware and cognizant of that. And as far as burns, stay away from hot things.
Okay.
That's kind of corny, but it's kind of corny, but it's true. Stay away from hot things. But I want to say thank you for everybody who came onto the call and spend time with us.
I'm going to add a little bit to your summary there. You said to be aware of getting the medication, to read those inserts. But I believe when in Tanzania right now, when they're getting a prescription, it's not in like a original bottle. So, you know, like you're dispensing the count, and then they give you in a little manila envelope to say, go and take this. twice a day, once a day, or whatever.
Mhm.
So they don't get those little insights like when you get here on the package with explanation of what medication for indications, contraindications, and alerts. So they don't get that. So chances they might not be able to know the extent. And most of the time, if you send maybe your child or your parents or somebody to go to the pharmacy to get the medication for you and then bring it to you. So sometimes the dispensation of the medication is not from the pharmacist to the patient, it may be pharmacist to the relative or a child or whatever who is being sent to get the medication. So sometimes it's hard to get that direct one-on-one with pharmacy consultation here in Tanzania. So I do agree. I think as a healthcare workers, we can take upon ourselves in Tanzania, for example, to share that information. When you are prescribing that medication to that patient, that's the teaching moment you have. So the patient will know what to let you call back or come back to the hospital when those effect happens. Because remember, sometimes they go to the remote area where there's not accessible to phone. Say, okay, call my doctor and say, oh, I'm getting these blisters. What the heck is this? So they might not get that chance to come back. By the time they come back, it's already too late, and things got worse. So I think if we get to increase our teaching when we're dispensing the medication or ordering the medication, I think it's absolutely variable. That is just even for outpatient, also inpatient, because the patients are in the hospitals. When they're giving them medication, we have to be teaching moment right then and there, because at least that one we can. We have the captured audience, the patient is like right there. So, okay, you're gonna take this medication. This is what is going to happen. This is a good thing. But if this happens, it's a bad thing. Come back or go to the nearest hospital or go to the nearest doctor to help you. So at least those ones we need to make it clear because I think our patients are very receptive, and anything we say, they will take it with 100 gold. Because whether we know what we're saying or not, but they will trust everything and they would never question us. So we cannot take that for granted. We have to take an extra step to explain to our patients and educate them. So we make sure that they don't get hurt. Mr. Pranka, you have your hand raised.
Yes, I was going to say that we had not, I don't think Anna Malele introduced herself, and I don't know if Khadija has something she wants to add or anything like that.
Anna? I think she did say from somewhere.
Add that patient teaching is key, because also you may not ever see that patient again. So that's important, is to tell them every precaution, or teach them how to take every precaution for whatever you're prescribing them upon discharge, whenever they can experience a condition like that.
Great.
And I'll echo the sentiments. That was a great presentation. I love the flow, very informative. I learn more and more about about Victoria every time. So still looking forward to experiencing more adventures with you, Lady V.
Just don't get burned.
Stay away from the hot stuff.
Right. Yeah.
Okay,
But
that's
yeah.
it. I'm only going to eat cereal. That's it. Milk and cereal. That's
right.
No, but no, thank you very much. That was great presentation and a great learning opportunity, especially those case studies. Yes, visually, usually we learn better by seeing how bad it can get. So as a healthcare workers, we need to be able to get those situations and improve them to that lady who looks beautiful at the end and you never even know. The same thing I think they did it for Miss Bree. Now, I did not know that you experienced that, but just by looking at you, just because probably the doctors, nurses who took care of you, or the specialists, burn specialists, or at the hospitals who took care of you and make sure everything else is reversed and here as quickly as you can. And now you're brand new.
Yes.
Okay.
So Bree, what burn center did you go to?
I didn't go
to north.
No, I didn't go to a burn center because mine was so mild, but they were going to transfer me to Miami if I did need to go. Yeah. Okay. Because it was like my mucous membrane. So they were scared about my airway and all that stuff.
True.
But she got it quick enough. I would assume they figured it out quick enough. Kind of.
Okay, guys, thank you very much. We're going to bring her back, Lady V. If you have any question, again, send them to Dr. Gabone QHSC at gmail.com. If you have any comment or something, we have a website. My number is everywhere on the WhatsApp. So if you put the Gabone QHSC, you'll be able to find us and send your questions. So then next time when she has a presentation or training, then she can answer those questions or send the email, and then I can forward it to her if you need direct information from specific hospitals. So then she can work one-on-one with you guys, so then you get more information. But in 18 days, she'll be in Tanzania. She'll be in Tanzania. So if you have anything that you're gonna be in the Dar es Salaam area, so let us know, send us questions so she can prepare and come with all the answers that you need for those incidents. So thank you very much. And I will let you guys go. It's Monday. So have a blessed week. Bye, everybody.
Wanakuja Dar es Salaam.
Yes, anakuja Dar es Salaam. Get ready, guys. Stay away from the heat. Don't get burned.
Bye-bye, everybody.
Hey, Dina.
Hey, Dina.
Miss Dina, come on. You've been just there quiet.
Karibuni sana Dar es Salaam.
Asante. You be. I know any burn patient at the Buguruni.
You say?
Wagonjwa ambao wana experience burn Buguruni now.
Of course, we have some patients who attend at Buguruni Health Center.
Okay.
But more times we transfer them to Amana Hospital.
Oh, okay. Okay. What about the diabetic wounds?
Oh, first aid, and then it transfer to Amana.
Okay.
Yeah.
Okay. Now that's good. That's good to know.
Excellent.
Thank
So
you.
it was good to see you. You always hide behind that phone.
Don't worry.
I know. We can't wait. We see you soon. Okay, bye guys.
Kumi na nane.
Okay, karibuni.
Okay.
Karibu Victoria.
Karibuni.
Nashukuru.
Asante.
Okay, bye guys.
Bye.
Bye.